poultry, eggs, touching pet turtles. Let's put that on that for you. Like hedgehogs, turtles, chicks, ducklings. So that's a question you should ask your patients too if they suddenly get this infectious diarrhea. Do you have any new pets at home? You know, that's another. Have you been to any water parks or pools at shady hotels, things like that? So there's all kinds of historical questions that can help you when you're taking history on diarrhea. But definitely for salmonella, it's undercooked poultry, eggs, boiled eggs, sitting out. People that take acid-lowering medications are at higher risk for this. We make acid in our stomach for a reason. It's not only to aid in digestion, but it actually has an antimicrobial effect as well. So people that are acid suppressed on H2 blockers or really on PPI, chronic use of PPIs are going to be at higher risk of these type of infections. Same type of symptoms as any inflammatory diarrhea: fever, pain, bloody stool. Again, this one usually resolves on its own without any antibiotics. If you need antibiotics, fluoroquinolone, something broad spectrum. But you only want to give those if they're really severe, like I'm going to give you this antibiotic to try to keep you out of the hospital, that type of thing. Or if they're just, their bloody stool will not stop, or it's been going on for more than 3 or 4 days, just go ahead and give the antibiotic. Oh, another thing I want y'all to know about this one is it's shed in the stool for a month after the infection's over. Okay? So if your hand washing and your food hygiene is not real great to begin with, and you think you're well and don't have any diarrhea anymore, well, actually you're shedding this in your stool for weeks after you're well. So there's a severe type of the salmonella infection. You guys have probably heard of typhoid fever. This infection is, this person's going to be very toxic appearing, very sick, super high fever, I mean up to 104, rigors, chills, lots of diarrhea. But these patients, the classic symptom really isn't necessarily diarrhea. These patients can actually feel constipated, bloated, not want to eat, but it's the really high fever that's most representative of this infection. So for people that live in the U.S., they usually pick it up when they're traveling. It can actually take up to a month for it to incubate. So they might come home from a trip and they don't develop this symptom till weeks later. I had a patient I saw in GI that came from Morocco who had gone back with her fiance, and they had eaten, just with his family, normal. She was fine when she came back. So it wasn't like classic traveler's diarrhea. But like 4 to 6 weeks later, she developed this bloody diarrhea, abdominal pain, and high fever, and ended up having this back on a culture. So there is a chronic carrier state with this infection as well, which I find kind of fascinating. Has anybody heard of the Typhoid Mary story? Anybody not heard of who Typhoid Mary is? Anybody want to hear the typhoid story?
Yeah, I've never heard of
So
that.
she was an Irish immigrant. She immigrated in 1906, or well, I don't remember if she immigrated actually in 1906, but in 1906, no, she immigrated before that. 1869 is when she immigrated. So she came to the United States. She started working as a cook, and she ended up in a single year infecting 33 people with typhoid fever. So they couldn't figure out where this was coming from. So it's just like when public health was just starting, trying to figure out the source of it's more like Sherlock Holmes for infectious disease. They literally tracked her down and were getting like samples from her out of the trash to try to figure out if she had salmonella typhi in her feces. They figured out it was her because she moved out of the city one summer and worked just for a single family on like Long Island or something, and she infected like all 10 of them. All 10 of them got typhoid fever, and she was the only change was that she came to work for them for the summer. So they ordered her to be confined. They confined her for like in quarantine, like imprisoned her for 2 years because of these 3,000 cases that got loose in New York City, and she was like patient 0. So I don't know why anybody hasn't made a movie about this yet, because it would be fascinating. But politics changed, and something got changed in the health department, and they were like, that's wrong, we shouldn't keep her confined, so they turned her loose, and another outbreak. Because guess where she went? She had to be released from prison with the agreement that she would not go back and work as a cook. And guess what she did? She went back and worked as a cook, and then infected a whole bunch more people. So it ends up, this whole saga goes on. They throw her back in the quarantine, and they did an autopsy on her after she died. She had salmonella typhi in her gallstones. Yes. So she had a chronic cholecystitis with gallstones in there, and she was shedding them out through her common bile duct and her juice, her gastric, or in her biliary juice, and from there, I don't know how it was getting in the food, but I wondered if she had a bad case of hemorrhoids or something. She was scratching her butt. I don't know how she was getting it chronically from fecal to the people she was working for, but she ended up, I don't remember how many people she killed. A lot of them, several of them died from it. So anyways, interesting.
I heard that she would switch from like houses to houses, like they would get infected and she would like leave in the middle of the night.
Yeah.
And then like go home to my store.
Right, it's crazy that she would just quit cooking for people.
Yeah. She refused to believe that she was
Yes. Quit cooking for people.
When did they start the like wash your hands before you do everything? Is that after her?
Well, at that stage in time, they were still doing surgery with bare hands.
Yeah.
There you go.
So
Probably just never wash their hands after
I
that.
doubt they were even washing. So another big inflammatory one is Campylobacter. This one can cause a dysentery, but it can also cause just a milder traveler's diarrhea. The one thing to take home from this is there's a rarely can it cause Guillain-Barré. So that's one of the late complications for Campylobacter. But again, gram-negative, flagellated bacteria. You guys remember Clostridium difficile, antibiotic-associated colitis, can cause pseudomembranous colitis. So if you're ever scoping anyone someday and you see that, see that. But usually this is associated from having broad-spectrum antibiotics for some other reason, or being in a hospital or in a nursing home. Because this bacteria is a spore-forming bacteria, just similar to Clostridium botulinum. And those spores can just live on surfaces, and then you have to ingest it to get the top. It has to be ingested before the toxin's released. The spore has to be ingested, and then it proliferates, and then the toxin. So just, again, don't get overwhelmed with the picture. This one does make a cytotoxin. Some Clostridium don't. Some Clostridium difficile do not make the cytotoxin, A or B. So you all understand that Clostridium difficile lives in your colon, it's there, but not all species or not all strains of it make the cytotoxin. So when you check for C. diff, you check a toxin. You don't check a culture for C. diff. Because everybody in this room probably has C. diff in their stool. You have to, don't culture for it, check for the toxin. And you'll check for toxin A and B when you order that. I would say in my experience, most of the time the diarrhea is not bloody. Most of the time it's watery, it's a lot of it, there's cramping, there's sometimes fever, but it's the elderly more common than young. So vancomycin, flagyl used to be the go-to for this one, but there's too much resistance. So vancomycin orally, vancomycin by enema. And then what is the final, like, what do we do if we can't get rid of the C. diff? Poop transplant. Has anybody been a donor yet? Maybe someday. I need to start.
Oh yeah, didn't you have to like live in Boston?
Yeah, Boston has one of those.
Here's another one of these fun graphics I found. This is C. diff, the bully. C. diff bullies the other good bacteria. Listeria. Somebody mentioned bluebell. Listeria is going to be milk, dairy, yogurt, ice cream machines. Definitely if it's unpasteurized. That's another thing I don't want to get on my soapbox about.
People drinking unpasteurized.
People thinking somehow unpasteurized milk is like the thing to do. Like, I'm like, what is wrong with you? Again, rich people problems, first world country problems, right? Like, you don't know how good you have it when you're worried about drinking unpasteurized milk. So, actually this one, I put this in here, but it's not really diarrhea. Like, diarrhea is not usually, so when you're thinking of listeria, think of it as more of a, I don't know what this person has, but they have some type of weird infection, okay? Fever of unknown origin. They get this weird flu-like symptom, fever, encephalitis maybe, meningitis. Pregnant women are particularly susceptible to listeria. This would come back on a blood culture. I mean, this would be something that, like, you're working up a, I don't know what this patient has, and you do blood cultures and it comes back with listeria. But what you need, what brings it back to infectious diarrhea is the fact that they got it fecal oral at some point. And I'm not going to hammer you guys on treatments, okay? I want you to know generalities. Who probably needs an antibiotic? Who just needs supportive care? Which patient needs IV fluids? Which patient needs oral rehydration? So don't go around memorizing, okay, well, she on listeria, ampicillin, and gentamicin, and IV Bactrim if severe. I'm just putting those up there for you to know. They need an antibiotic, okay? And you're going to have to look it up when you're on rotation tables. Yersinia is another one that causes inflammatory colitis. Yersinia is the classic right-sided abdominal pain, and you think they might have appendicitis, okay? So if they come in with infectious diarrhea, fever, you're thinking, well, this might be appendicitis, well, it also might be Yersinia, okay? This is one you have to actually add on a special culture if you want it cultured for. So if you suspect it, you have to order it on a special auger. You have to grow it on a different medium than just a normal stool culture. Yes?
Sorry to go back, is the listeria the one that's in lunch meat, that pregnant?
Yes. It can be on a lunch meat too. But if you think this, if it's pregnant woman, it's listeria. That's a word question. And then we talked about amoebic dysentery. There's, one amoeba that can actually be invasive, actually enter into the colon wall itself. That's this little guy. Okay, so if you have a patient that, just like with the tick-borne illnesses, they have a fever after they've been camping, or they have a fever after they've been on a hunting trip, right? This is if they come back with diarrhea after they went hiking in the mountains and drank from a mountain stream. It's going to be giardia. Yeah. So these patients, it's a different presentation. They might not present acutely, like with traveler's diarrhea. They might just kind of have some stomach upset, and then they get this diarrhea, and it goes away, and then they get some diarrhea again, and it goes away. If it kind of persists over 2, 3, 4 weeks, even up to months, then it's probably a protozoa. These patients are confusing with other GI illnesses because they come in and they're like, they might have IBS, they might have lactose intolerance, they might have pancreatic insufficiency. So you kind of have to work them up. That's why even if you think you're treating somebody for IBS, go ahead and check the stools because you might pick up something like this. They might have forgotten that their symptoms go back a year and oh yeah, it started after that camping trip or that hike or whatever. But your board question will be, some dude went hiking, drank out of mountain streams, he was so thirsty, and then he has diarrhea. It comes and goes, gas, sometimes weight loss. So the pathogen is Giardia lamblia. It actually can survive in a cyst form in water for months. Especially, that's why it's the mountain stream and not the beach, because it survives in cold water. Cold, fresh water. It's the most common intestinal parasite in our country. So these guys, you actually ingest the cyst form, because the protozoa itself has to be in the gut to live. So you actually ingest the cyst. The cyst releases the trophozoites, or trophozoite, singular, in the small intestine, and then that little guy like splits into 2. So these can grow exponentially real quick. Spread, I guess. And then when it gets back to the colon, encystation takes place again, and then you poop out the cyst. So that's how its life cycle goes around. Pretty cool. So these symptoms are different. It's bloat, it's gas, kind of, they'll actually get malabsorption from this, foul-smelling, greasy stools, weight loss, signs of malabsorption. And you have to actually order a microscopic study of the stool to see these. You will not find these on a culture. You have to order a stool for ova and parasites. Okay? So anytime you're working up infectious diarrhea, even if you think you know what it is, order the O and P, order the culture, order the fecal leukocytes. Yes?
So Doc, do you just would you want to do multiple days? Or just one, is it just one sample?
Right, so for this, if you suspect that if it's a persistent protozoa, you want to check more than one specimen on those. Okay, so like how I would approach this patient is I would check all the stools. If I don't get it back, I would still treat him if I suspected it. I'd give him a round of flagyl. If it doesn't get rid of it, then I'd check another sample. So don't give up on this one if you really suspect that that's what it is and the first one doesn't come back positive, because it can be intermittent shedding. The other protozoa is the one you get at the water parks. I always think of like dirty diapers in the public pool, you know, poop water. So again, ponds, pools, stagnant water, streams. The thing with this one is you don't need a whole lot of this to get infected. You can also get this one from animals. And it's resistant to chlorine. So this one, abrupt, profuse, watery diarrhea. So this is going to be more of a secretory presentation. But this one is so intermittent. The person might think, oh, I'm over it. It's better. And then like the next month they have another bout of it. And then they come to your office because they're convinced they have colon cancer or something. You know. But it's watery diarrhea. Is that how colon cancer presents? But Dr. Oz said So most of the time in just normal people with good immune systems, you fight it off, it goes away, no big deal. But like what the take home for this one is in the HIV positive patient or an AIDS patient, it can become really severe. Okay. Blastocystis hominis. We really don't know if this is a pathogen or not. It's so ubiquitous everywhere in water. Nobody really knows what it is. It's in the same genus as slime molds and algae. But for some reason, we have people with persistent diarrhea. Check their stool, we find this. We don't know if it's a problem or not. It probably is in a certain subset of people. But again, really common. You find it in well people, you find it in sick people. Really don't know if it's a pathogen or not. Some people have it in their stool, have no symptoms at all. They just live with it. The weird thing with this one is this causes anal itching. So, I actually checked this on a guy one time that kept coming back to clinic with anal itching over and over and over. We treated hemorrhoids. He's like, I saw a dermatologist, okay, I'm gonna pull this out from, I don't know where, but we're gonna check for a stool and O&B, and they didn't have it. And it didn't help. You guys have already done Clostridium, right? Don't give babies honey, right? Okay, I'm not going over this one, which I already have it. Okay. You guys can probably name some big things that are on your differential, right? You've already listed IBS, ulcerative colitis, Crohn's disease. It could be a medication they've taken. It could be something they've eaten. Taking a history on diarrhea is actually kind of fun because there's a lot of things you can ask that are actually really helpful for your differential list. So ask about food, ask about travel, ask about occupation, ask about kids, ask about, did you eat honey smacks? There's an outbreak in your area, Blood in the stool, pain, fever, how high is the fever? Is it watery? Is it small volume, but lots of stool? Or is it tons of watery diarrhea? That already helps you separate it into inflammatory versus secretory. It's just more what we're talking about. You guys don't memorize this, but you need to have a broad understanding for what medications cause diarrhea, right? Your obvious ones are you overdosing yourself on laxatives, right? Have you been taking laxatives? You always ask that one. But, so anything magnesium containing, your big one is metformin. I mean, how many have already seen that in Good Shepherd? Everybody's on metformin. And it can cause diarrhea. NSAIDs are a big one. Always ask about supplements. People take, well, I take this supplement and this supplement and this supplement, and then they all have magnesium. It's like they all have a magnesium in them. No wonder they're going to be diarrhea. And then make sure they're not taking some kind of liquid medicine that has a bunch of sorbitol or mannitol in it. Artificial sweeteners that are in like cough syrups or things like that. So again, don't worry about memorizing this. I just want y'all to need to have a broad understanding for what meds do I need to be asking about or looking for on the chart if somebody's coming in with an acute diarrhea. Please assess dehydration first, okay? It's your most severe threat with diarrhea, so check the skin turgor. Vitals are the most important thing of all, okay? So blood pressure dropping, are they tachycardic? So assess dehydration, administer fluids. That's the first thing you're going to do in these patients, right? Well, how bad are they by the time they're getting orthostatic or postural? I get up, get up from a seated position and I get lightheaded or dizzy. Well, they've already lost 5 to 10% of their total body weight at that point. If they're getting to be really tachycardic or you can't even feel their pulse, the pulse is thready, then they've probably lost 10% or more of their total body weight or volume. You guys can look at, study that later. Again, remember your red flags. If it's gone on for more than 2 weeks, there's evidence of bleeding, there's high fever. Of course, you guys are going to start workups, do your workups, because that's how you learn, you work it up. I mean, I did it too when I was first out of school, but still remember your red flags. What do you order? Fecal leukocytes, stool for O&P, and a stool culture. You can add on the collar culture, add on the Yersinia culture if you need to, but most of the time you do not need to add those. Okay, so just do a standard stool culture. CBC is going to tell you about platelets, it's going to tell you about anemia. Somebody's extremely dehydrated. They're fairly hemoconcentrated, right? They're going to have really good hemoglobin, or really good hematocrit, rather, not hemoglobin. What happens when you resuscitate them with IV fluids? Their hemoglobin suddenly drops, or hematocrit drops, because you give them all this fluid back. So just know that for common knowledge. If it doesn't drop more than 1 gram or so, don't worry about it. And of course, if they're bleeding, and you check it one day and it's 14, you check it the next day and it's 11, that's not from fluid resuscitation. That's from bleeding. So what do you give them? Fluids. Can they take a PO? Give them PO fluids. If they have cholera, you give them the sugar, the glucose fluids, but you don't need to do that for everything. You give them IV fluids if they're so sick they're vomiting and can't keep anything down. You can use anti-diarrheals, Pepto-Bismol, give them some antiemetics. I usually, if somebody comes in with acute gastroenteritis, I tell them just don't put anything in your mouth for 4 hours. Go lay down. Don't eat or drink anything. Moms want to start shoving the Sprite down and shoving the crackers down. And like just let them work it out. Let their body flush everything out and then give them the sips. Sips of water. Show the mom how to check the skin turgor. So, tell her to look for sunken eyes. Check the fontanelles on the babies. Don't just, if they're throwing up and sick, let them work it out for a little bit and then keep checking them. Don't need to be pounding Pedialyte right from the very beginning. Be aware of late complications. Okay, you can get a Reiter syndrome with some of these bacteria that are fairly aggressive. And of course, you all need to know hemolytic uremic. And it's usually tied to E. coli. It can be tied to Shigella, but most of the time it's E. coli 0157H7. Yersinia can get fairly widespread systemic autoimmune type reaction with, and then any infectious diarrhea, somebody can end up with post-infectious IBS. And then I also mentioned earlier, I think there's some post-infectious ulcerative colitis that happens as well. Has anybody talked to you about the Sanford guide? Now, I don't know how Dr. Latassi feels about this, but this was like the Bible for picking what antibiotic. I know y'all use Up-to-Date sometimes, but it's kind of high, kind of expensive. I mean, this is like a pocket guide. It's like that book. It tells you what the current recommendation is for everything. So you just look up whatever you're treating and pull it up. Now, there may be an app version as well. I don't know. I have no idea how much it costs, but I think it's extremely helpful for telling you what antibiotic to give for what problem. Okay? So just look at that. That's what the rotavirus vaccine looks like when you give them squirted in. Cholera vaccine, just preventative measures. Wash your fruit. Oh my gosh, and boil it, cook it, peel it, or forget it. That's what I was trying to remember. Don't eat out of food carts in foreign countries. Don't drink margaritas. Don't get drinks with ice. You need to pop that beer yourself. Don't eat salads. I know that one from experience. To only eat fruit you can peel yourself. Pineapple, you can cut open yourself and know it's going to be fairly safe. Don't pick up an apple and bite into it. Peel it. Again, don't eat from street vendors. You can boil for 1 minute. And then bottled water, even for brushing teeth. All right, any other questions or anything? That's just for y'all to use for when you're looking at your pathogens. Everything else is just stuff on there for y'all to use. So, I love those. I don't know if they help y'all or not. All right. What else about food? Anything? Y'all have got the message that Pepto-Bismol is highly underutilized, right? Yeah?
Let's talk.
Let's talk